This week for our weekly Wednesday webinar. We're going to just take a moment, like always, and let the room fill up before we go ahead and get started. If you're joining us from one of our live streaming platforms, hello, nice to see you guys again. We'll get started in just a moment. Hello, hello. We're going to give it just one more moment before we go ahead and kick off this week's Wednesday webinar. Okay. All right, well, good afternoon, everyone. Thank you for joining us once again for our weekly Wednesday webinar series. Today's webinar is on a real-world study of rurioctocog, alfa, pegol, and emicizumab in U.S. clinical practice among patients with hemophilia A. My name is Alsan Rutha, and I'm the Manager of Strategic Communications here at the National Hemophilia Foundation. At any point during the webinar, if you would like to ask a question, please use the Q&A feature at the bottom of your screen. And as always, if you're joining us from one of our social media streaming platforms, you can enter your questions in the comments. We have NHF staff members monitoring these questions, which we will post to our speaker after the presentation. This webinar is being recorded and will be available to the community beginning on Friday, February 10th. I am joined today by Dr. Jonathan Roberts, Associate Medical Director at BCDI. He works with pediatric and adult patients with hemophilia. Thank you for taking the time to join us today. I will go ahead and turn it over to you, Dr. Roberts, to get us started.
All right, thanks very much for joining us today, and thank you to NHF for the kind invitation to highlight our work. And so on behalf of myself and co-authors, I'll be presenting our paper, which was recently published on a real-world study of rurioctocog, alfa, pegol, and emicizumab in U.S. clinical practice among patients with hemophilia A. And for maybe some of you who are watching today that aren't familiar with these two medications, rurioctocog alfa pegol is Adinavate and emicizumab is Hemlibra. And so we'll be discussing these obviously throughout the presentation. Here are my disclosures. All right, so without further ado, we're all familiar that hemophilia A is an X-linked congenital bleeding disorder that is caused by deficiency of factor VIII. And it's been well established that regular replacement therapy, rather, with plasma-derived or recombinant factor VIII has been the mainstay of hemophilia treatment. We know that there's additionally one other non-factor therapy currently on the market with emicizumab that's also indicated for prophylaxis. And everyone is well aware that prophylaxis is recommended over on-demand therapy to maintain hemostasis and to prevent bleeding in patients. So just a little bit of a reminder for these two medications that we're talking about. Rurioctocog alfa pegol, or Adinavate, is a full-length recombinant extended half-life factor VIII concentrate manufactured by adding a branched polyethylene glycol, or PEG, molecule to the octocog alpha molecule. It does extend half-life, and efficacy of its prophylaxis was demonstrated in an open-label phase 2/3 clinical trial where around 40% of patients with severe hemophilia A had no bleeding episodes over 6 months with a twice-weekly prophylaxis regimen. The median ABR, or annualized bleeding rate, was 1.9 versus 41.5 for patients on demand. And so again, knowing that prophylaxis is indicated for patients with severe bleeding, certainly with this medication shows good efficacy in that regard versus on demand. Similarly, emicizumab is the first non-factor therapy approved for routine prophylaxis in patients with hemophilia A and is administered by subcutaneous injection, which makes it unique compared to other factor products. In the HAVEN 3 trial, 152 patients with severe hemophilia A without inhibitors were randomized to maintenance prophylaxis with emicizumab at the doses listed there, weekly or every 2 weeks versus no prophylaxis. And the prophylaxis arm was associated with a remarkable reduction in annualized bleed rate as well. So again, both molecules shown to be efficacious in prophylaxis. However, the clinical impact of switching other factor VIII products to emicizumab or an extended half-life factor VIII in US clinical practice remains underexplored. And specifically, there's been no studies comparing product utilization, including wastage. By wastage, I mean a drug that is not administered to the patient, but is prescribed or the patient has access to. And so this was looked at with emicizumab versus a factor VIII concentrate with the rurioctocog alfa pegol that we're going to talk about. So our objectives of the study was to evaluate and compare the utilization wastage and the clinical effectiveness per the annualized bleed rate or ABR of prophylactic treatment with emicizumab or factor VIII being ruri in patients with moderate to severe hemophilia A without inhibitors in US clinical practice. Breakthrough bleeding and utilization of additional factor VIII for management of these bleeds were also compared before and after switching to ruri or emicizumab from another factor VIII prophylaxis product. So how did we go about this study? So this was a retrospective observational cohort study that used database data from Trio Health Specialty Pharmacy Partners from July 2017 to May of 2020. And this study did meet criteria for IRB exemption as the data were stripped of personally identifiable information. So this was an evaluation of a pharmacy database. So in looking at the patients and the study design, the study included male patients with moderate to severe hemophilia A. So factor VIII level was less than or equal to 5%. And you can see here in our figure here that patients were on a previous factor VIII prophylaxis and then received either emicizumab after at least greater than or equal to 6 months of prophylactic factor VIII or prophylaxis with rurioctocog alfa pegol after prophylaxis with factor VIII. We also did look at octocog alpha, which is Advate, without switching to other prophylaxis during the study period. However, data for the octocog alpha was excluded from the report because of a limited sample size and lack of pre-post switch data for within group comparison. So we're really going to be focusing on emicizumab and ruri, so extended half-life factor VIII and a non-factor product. And we captured patient characteristics, prophylaxis frequency, prescriptions, the doses dispensed, bleeds the patients reported, and the medication for bleeds were also analyzed. So our primary outcomes was to look at the total mean weekly consumption of factor VIII and emicizumab, the dosage frequency and product wastage. The total mean weekly consumption included factor VIII and emicizumab used for regular prophylaxis, and if there was any additional factor VIII used for breakthrough bleed management. Utilization for the treatment of breakthrough bleeding was based on the number of infusions required to treat the bleed till resolution, and the dose listed in the bleed log or closest on-demand prescription before the bleed. The prophylactic frequency was determined using the dispensing and prescription data from the providers for the patients. And wastage of emicizumab and ruri was defined as extraneous drug in the vial based on the prescribed dose versus what was dispensed in the vial. Secondary outcomes that we also evaluated were all breakthrough bleeds, including but not limited to treated bleeds, evaluated as the annualized bleed rate. So this can be difficult, right? Because we're trying to look at different patients that are prescribed different medications. So how can we ensure that there's better statistical fidelity in the analysis of our data? So to reduce the effect of baseline differences for the EMI and RURI cohorts for between group comparisons of the post-index utilization, so after they switch to these medications, and the potential changes in ABR, we used a method called propensity score matching that was performed based on the age, the severity, and the pre-index ABR of the patients. So basically looking at this figure, looking at how we went about the propensity score matching, we looked at the age of the patient, 0 to 9, 10 to 19, or greater than or equal to 20 years of age, that they were severe, and that they had a similar pre-index ABR. We then performed statistical analysis on the ABR estimates, and we limited this to the overall ABR. So we're going to go through the results of this. the patient population and prophylaxis dosing frequency, the characteristics and treatment utilization, wastage, and overall the clinical efficacy. So data was obtained from 216 patients treated by 314 prescribers at 87 practices across 40 states of the US. So this is quite a diverse population across the United States that was evaluated in this pharmacy database. You can see that 97 patients were excluded because of insufficient pre or post-switch treatment dispensing history. There are a few other reasons here, such as no emicizumab was dispensed beyond the loading dose in some patients. Some patients had less than 6 months of prior dispense history. There was some poor history on prophylaxis and other few reasons listed there. So the analyzed and included set was 103. And importantly, patients that were on emicizumab were primarily weekly, 48% in all patients and 46% in the matched cohort. So we're going to talk about, we matched patients on emicizumab prophylaxis to be similar to those on the EHL factor VIII or the RURI cohort. And then some patients were also on Q2 week, every 2-week dosing was 40% in all patients, or 42 in the matched cohort for the emicizumab prophylaxis cohort of patients. So I'm going to go through a lot of data here, but compared with the overall emicizumab prophylaxis cohort, patients in the EHL or the RURI cohort tended to be older and also had a higher proportion with severe hemophilia. And the RURI group also had a significantly higher proportion of patients with more target joints. So patients on the EHL were a little bit older and had more target joints than the EMI cohort, despite the propensity score matching that was done. The total mean weekly consumption of prophylactic factor VIII and EMI, as well as additional factor VIII to manage breakthrough bleeds, was shown in table 2, and we're going to look at the tables on the next slide. Pre-index emicizumab patients had a slightly lower mean weekly total factor VIII consumption than the RURI group, pre-index, so before the switch. And then post-index, the overall consumption of additional factor VIII to manage breakthrough bleeding decreased in all 3 cohorts versus the pre-index consumption. Further, the total mean weekly consumption of factor VIII for breakthrough bleeding, treatment or prevention post-index was higher in the EHL group or the RURI group. And this was largely driven by a single patient, and we actually did analyze the data with and without this patient that had a large amount of usage. So if you look here at the tables, we have broken down by the overall emicizumab cohort and then the matching that we did compared to the EHL or the RURI cohort. You can see the ages of the patients. Obviously, the RURI cohort was only 18 versus many more on emicizumab, and the match group for emicizumab was 54. And you can see the in general as well, there were more target joints for number of patients in the EHL group than the emicizumab group. Then we also looked at the total mean weekly consumption of on-demand and prophylactic factor VIII and emicizumab. You can see here the pre-index, so before the switch, the amount of factor VIII that was used in both of the groups, paying in particular, paying attention to the matched emicizumab group, and then also the RURI group where the outlier bleeder was removed. And then post-index, also looking at the amount of factor VIII that was used on demand for medical procedures, for bleed prevention, and then the amount used for total factor VIII consumption weekly as well, which is shown there on table 2. So then looking at wastage, some patients had negative wastage as dispensed factor VIII prophylaxis was less than the prescribed dose. And the increase in product wastage in the emicizumab cohort post-index versus pre-index was statistically significant in both the unmatched and the matched cohorts, whereas there was no difference in wastage in the RURI group. So what does that mean? So, you know, it has to do with the dosing availability and the vial size of the medication for the patients. So basically meaning that in the emicizumab group, because, you know, all of these medicines are weight-based dosed, that there was more extra drug left in the vial for emicizumab versus the EHL or the rurioctocog alfa medication. And the mean annualized wastage of EMI during prophylaxis was around 330 milligrams. Also, patients with EMI wastage was correlated with a more increased frequency of admission. So as you would kind of expect, patients that were getting dosed weekly then had more opportunity for excess drug to be left in the vial versus those that were not on emicizumab. So in looking then at clinical efficacy, so patients in the RURI group had a higher pre-switch mean joint ABR, about 1.3 versus 0.89, and trauma injury ABR was a little higher than the matched EMI group, but also they had lower spontaneous bleeds, 0.58 versus 0.6, and spontaneous joint bleeds. And post-index, actually, no differences were observed between the cohorts for all bleeds for each bleed type, suggesting similar treatment effectiveness. So basically, the take-home message being that when patients were switched to either the EHL or to EMI, there's no differences in the amount of, or what their ABR was rather, after the switch that suggests that there was some similar efficacy as long as the patient was on prophylaxis with either of the molecules. So overall, we evaluated the effects of switching patients to prophylaxis with RURI or EMI in U.S. clinical practice with a focus on clinical effectiveness, the treatment utilization, and product wastage. ABRs were similar for the RURI and EMI group during the post-switch follow-up period that suggested that they had similar clinical effectiveness, as I just mentioned. ABRs decreased from the pre-switch period for both treatments, with no significant difference between the cohorts. And patients in the RURI cohort did not have a significant decrease in spontaneous bleeds post-switch. This perhaps could be also of an inflated standard error because of limited sample size, because we are talking about 18 patients. So that is a difference compared to the emicizumab group. Similar bleed rates during the EMI and RURI prophylaxis contrast with previous analysis that's been done in which the ABR is compared before and after switching from to EMI from factor VIII prophylaxis. So, for example, a subgroup of patients from Haven 3 showed a 68% reduction in ABR after switching to EMI from previous factor VIII prophylaxis, which actually were mainly standard half-life products, so not products like RURI in a non-interventional study. However, only half of the patients in that study had relatively high, and by that we mean greater than 80% factor VIII regimen adherence. And the findings might have been affected by a selection bias, as there's no comparator group of patients who would switch to another factor VIII product. Also, as mentioned, product wastage with EMI prophylaxis was significantly higher versus RURI, with wastage positively associated with the emicizumab dosing frequency. So the more wastage, the more frequently that you dosed. So our findings of reduced product wastage with RURI versus EMI is consistent with previous research that shows that a broader selection of dosing strengths is associated with improved dispensing accuracy of hemophilia A treatment. And our analysis did have methodologic strengths that support the comparative efficacy of EMI and RURI because we use the propensity score matching to reduce the effect of this baseline differences between the cohorts. That is a strength of the study. Also, the hemophilia A severity and the number of target joints were lower in the unmatched EMI versus RURI group. So the greater number of target joints were noted in the RURI group, could be secondary to the higher average patient age as well. Limitations of our study are similar to retrospective observational studies in that patients were not randomized and observers were not blinded. And the RURI group was relatively small. Again, the matched EMI group was 54 patients versus 18 in the RURI group. And some bleed data that was collected in the database were obtained directly from patients and caregivers and are subject to recall limitations, which is always a challenge in studies where we're talking about therapies that are done at home. We are limited by the recall of patients for the bleeds that they had and the accuracy of their description to their pharmacies. So in conclusion, to our knowledge, this is the first study to assess the effectiveness of EMI versus RURI prophylaxis in clinical practice, while also assessing the product wastage utilization of additional factor VIII to manage breakthrough bleeds. Bleeding rates were similar for patients receiving prophylaxis with EMI or RURI after switching from prophylaxis from another factor VIII product in real-world clinical practice, suggesting similar treatment efficacy if patients are undergoing prophylaxis as prescribed. And wastage associated with dispensing inaccuracies was greater with emicizumab. So with that, I thank you for your time and attention. And we do have some time for questions, which I see we have here in the chat. So
Yes. We'll get started in just one second.
Do you want me just to address them or
yeah.
them or
Let me go ahead and share my screen real quick because I do have just a few announcements to make. Let me see real quick and then we'll get started on the Q&A. It is time to lace up your running shoes. NHF is participating in the 2023 United Airlines New York City Half Marathon on Sunday, March 19th. We are now accepting applications to represent NHF in the United Airlines New York City Half. Travel stipends are available. Visit hemophilia.org/events to learn more. And one more announcement, nominations for awards of excellence are open through May 5th. You can visit hemophilia.org/BDC, go to the program tab and click awards of excellence. And then from that page, click the button for the nomination form. Self-nominations are not allowed at this time, but you can always ask someone to nominate you if you wanted to. We look forward to seeing you this year at BDC. Okay, so if you want to address the ones in the Q&A, we can go ahead and do that. We can start with the how does this data impact how you would treat a patient question?
Yeah, so that's very good. I mean, I think, this really does not speak to the choice that, people have in what prophylaxis regimen works well for them. So, I mean, I guess in regards to treating a patient, what these data do suggest for both Adynovate and Hemlibra patients, if they are taking their prophylaxis, that we showed that they're, at least based on ABR in what we were looking at, in the data, that they had similar effectiveness, that their ABR was no worse whether they were on the emicizumab or the RURI. So, really, I think it comes down to patient choice and what medication works well for their lifestyle. I certainly have patients on both. And I think the benefit for the hemophilia community is that, we actually do have a choice. I mean, I didn't say it in my intro, but I also myself have severe hemophilia A. So I've lived through the evolution of therapy over the past, couple of decades, let's say. And I think these data, are reassuring that both of these molecules work well for prophylaxis. So I don't think that this really pushes me to treat a patient with either molecule one way or the other. I think we have an open discussion, and certainly the data we highlight in the study can be part of that discussion. So good question.
Wonderful, thank you. So if a patient bleeds on EMI, do you find greater success in SHLS or in EHLS for breakthrough bleeds?
Yeah, so that wasn't directly looked at with the study. Thankfully if you look at the data from the Haven trials and other studies that are out there on emicizumab, a lot of patients do very well and don't have much in way of breakthrough bleeding. There's not data in our study to speak to if a patient should be treated with one product versus another, or an SHL versus an EHL. So all of the currently available standard half-life and extended half-life products on the market have shown efficacy, very good efficacy, in treating bleeds on demand. So again, I think that would speak to, if you are a patient that's on emicizumab and does experience a breakthrough bleed, I would speak directly to your provider as to what option would work best for you to treat that. So, and again, in our study, we are only looking at one particular EHL, the rurioctocog alpha pegol. Some patients also on octocog or advate, but those patients, there wasn't enough of a switch analysis for us to formally look at it. So that really we looked at just the EHL versus the emicizumab. So good question though.
Wonderful. Why would there be any wastage with ruri if the patient takes the dose in the vial?
That's a very good question. And it really, I mean, that speaks to the inherent differences in the molecules. So I mean, right, typically for factor VIII, we do have a lot of control on specifically dosing the correct amount for our patient, which actually in our discussion we highlight. I mean, that's why a lot of the manufacturers have made multiple dosing options available. And there's less of that ability with emicizumab, and I know the manufacturer is aware and considering this feedback as well. So, however, I will say it is important to follow explicitly the dosing recommendations, from your provider, that you're taking the correct dose of either emicizumab or ruri or whatever factor concentrate you're on or other treatment.
Do you think an EHL for breakthrough would provide better coverage terms?
Yeah, again, another good question. So if you're meaning, would an EHL potentially give you longer time between infusions? Yes, compared to a standard half-life product, but that's also dependent on your individual pharmacokinetics as a patient as well. So I really, to really answer that question fully, I would speak with your provider about whatever medications you're on, or what if you have a particular different one for a breakthrough bleeding event. I would recommend that you talk with your provider about what is your pharmacokinetic profile and what would be the best option for you. Obviously, some products between EHLs and SHLs last different times in the body. So if your goal is to get the longest acting, factor activity after an infusion for a breakthrough bleed, it would take some additional evaluation in you as an individual to really answer that question fully. Good question.
Why are real-world studies important, perhaps when compared to clinical trial-based studies?
That's a very good question. So we have to go through the clinical trial study, correct, to get products to market, right? We have to prove to the FDA and other international governing bodies that treatments are safe, that they're efficacious, and that they're used appropriately for the indications that we want them to be. But we know that the clinical trial is different than real world, right? So if any of you have ever been part of a patient on a clinical trial, I mean, I'll disclose I have a long time ago before my current role. There's a lot of rigor, right? There's a lot of rigor to dosing. There's a lot of rigor to the amount of follow-ups. And in general, we understand that patients on clinical trials, to be part of the clinical trial, have to follow the regimens that are outlined by the study protocol, or else they can't be on the study, right? So in the real world, we know how that goes. Am I, as a patient, always 100%, taking my factor therapy or prophylactic therapy exactly when I'm supposed to? It may not always happen. So the real world is important to see once a molecule gets into clinical practice. How is it utilized by patients, and it can confirm, do the things that we saw in the clinical trial really hold up? How are patients actually doing? So a benefit of our study, it's a little bit different, right? Because we didn't have patients enrolled at our center specifically that we were following and everything. We were looking at database analysis from pharmacy prescriptions, basically what patients were telling their pharmacy when they're ordering their medication, and trying to analyze a lot more patients across the country from a lot more diverse backgrounds. So a strength of the study is that we are able to look at not just one particular or a few particular treatment locations, but really at over 40 different centers across the United States to see how are these drugs being used in the real world. So really the real world studies can give a reflection of, maybe how as a patient you may expect a particular therapy to work for you. What can we what new information can we learn by looking at a medication while it's in the real world through a variety of treatment experiences versus the rigor that comes from conducting a clinical trial. So both studies are vitally important, but with us as physician scientists and researchers, really we need to do our due diligence to not just settle for the information that comes from a clinical trial from a small number of patients, but really to look at how are these treatments being used in the real world when people are living their everyday lives, and how does that translate to us making decisions for our patients. So hopefully that answers your question.
Perfect, thank you. Did this study look at locations of breakthrough bleeds?
Yeah, good question. It did not. We just looked at breakthrough bleed in general. So again, that's what the patient talked about. We did have if it was a joint bleed or not, but we looked at all bleeds and joint bleeds as well.
In your opinion, how would the study's findings look different if you had looked at patients with inhibitors?
Very good question. Well, so for one, we wouldn't be looking at the extended half-life factor product as a treatment, right? So if you had an inhibitor and you were on prophylaxis and you were not on emicizumab, your options, especially if it was a high titer inhibitor, would be really to use one of the bypassing agents, which we have an activated prothrombin complex concentrate or one of the recombinant factor 7 products. So it would be a different study altogether. I mean, if we're looking at prophylaxis and how patients did after switching, ME versus one of the other bypassing agents, it would be a completely different study. So yeah, we really couldn't look at the factor 8 products in the setting of an inhibitor because the inhibitor would be neutralizing that factor activity. So good question.
Were there any significant challenges in your research, and how did you work through them?
Yeah, I mean, I think the challenge was really trying to get enough of the different patients on the cohorts to do the analysis. So if you saw, there were multiple hundred patients that we looked at, and we found, some patients maybe, they started the loading process with emicizumab and then didn't continue, or when we looked at during that time frame, patients weren't on prophylaxis with either of the two medications for long enough to be included in our analysis, or there were inconsistencies in the quality of the data, maybe some of the questions we are asking about prophylaxis or joint bleeds, et cetera, that was not there. So that goes through the slide that we had on the those patients that were excluded from the analysis. After that, then it's going through meticulously the detail of looking at the data, the statistical analysis that we thankfully have our statistical statistician colleagues to help with that also, before we are able to draw our conclusions from the study. So
great. Let's see, how are critical databases like the one you used for researcher and patient population knowledge?
How critical are those databases? Yeah, I mean, they are critical because they allow us a data repository from which we can do these type of studies, right? So you can think about, we're talking about a real world study, but if we didn't have these data and we were trying to contact every treatment center across the country and have them, give us all of these data manually, a study of this magnitude would not be able to be completed because because of all of the nuances of trying to get those data and all the extra man hours that would go in to try to do that. So having these type of pharmacy databases being curated and available are critical for us to be able to do these type of studies. Similarly to, we're involved with Athen and, some of the data collection from that and other national collaborations that occur. And having these large repositories for data is very important to be able to do these types of studies. I mean, without it, it would be near impossible for an individual investigator like myself or a small group of investigators to be able to ask these questions and try to get the data to even do the analysis. So,
why do you think that older patients are less likely to try or be on EMI versus EHLS?
Yeah, so I don't know if I would draw that conclusion from the data we showed. I think every patient's choice is important, and there are many factors to consider. No pun intended for what prophylaxis regimen a patient is on. It just so happened that in the patients that we had in our analysis, they tended to be older and they had more target joints. So does that speak to more hesitancy in that population to go to emicizumab? I don't know. I know I certainly have patients myself of all age ranges on both of these products, and it's well tolerated. So when you look at a study, it's important to ask the questions that the data can answer and those that the data can't answer. We commented on it in our discussion to highlight that is a difference, that the patients, in the EHL, the RURI group, factor group, there were fewer patients. There were 18 versus in the matched cohort, 54 in the emicizumab. So there are more patients overall on emicizumab. So, with a smaller number of patients, it's difficult to tease out some of those questions. It happened that our group, yes, they were a little older and they had more target joints, more arthropathy.
Were there any conclusions from your study that you were relatively surprised by?
Yeah, I think I was, I don't know if I was surprised per se. I think we knew going into this, also looking at wastage, that just with the dosing vials that are available, that there probably would be some additional with emicizumab, but it's not been looked at in the way that we did in this study. Also, I guess I was not surprised, but pleased to see that patients, whether they were on either one of those medications, that there did not seem to be an increase in the annualized bleed rate. They had similar annualized bleed rate. So when looking at that particular outcome measure in isolation, right, because we're looking at a database, and so there's only so much the data can tell us, but that patients seem to do well on prophylaxis with both of the medications.
And for what could potentially be our final one, unless we get any more questions in the chat, what is the biggest takeaway you want the audience to walk away with from your discussion today?
Yeah, I mean, I think that the biggest takeaway is that, what I just mentioned, that in the real world, both of these products for prophylaxis, patients similarly had a reduction in your annualized bleed rate. So that is a reassuring thing for me as a physician scientist and an individual with hemophilia myself, that these products seem to be efficacious. And I think, some of the challenges with the stewardship of resources and drug wastage, certainly the manufacturer is aware of this, and I believe being considered. So I hope that studies like this highlight some of the challenges we see in the real world and, provide us with more information to be more fully informed as we make treatment decisions for our patients.
Fantastic. Thank you. Well, I'd like to thank you once again, Dr. Roberts, for taking the time to join us this afternoon. We appreciate your time and expertise. I'd also like to thank each one of our viewers for joining us. Please note that this recorded webinar will be available on Friday, February 10th at hemophilia.org under the events tab with all of our archived webinars. Also available in the events tab is our upcoming schedule for our weekly Wednesday webinar series. Thank you for joining us this afternoon and have a wonderful week. We'll see you next week.
Thanks very much. Take care.